how susceptible they are, depending on physical, social, or economic factors. Children, as we will see later, significantly increase the vulnerability component. Disaster risk appears when these three elements. However, the same heat wave affecting a populated city with many children or limited resources creates a much higher risk. By understanding resources and design prevention strategies. So disasters are not only about the hazard itself, but about who's exposed and how vulnerable they are. The framework for disaster risk reduction is the main global strategy guiding how countries should manage disasters. They have defined 7 global targets to achieve by 2030. On one side, the goal is critical infrastructure strategies, improving international cooperation, and expanding access to early warning systems. So the idea is not only to reduce the negative impact of disasters, but also to strengthen the capacity of systems to respond and adapt. They have defined how to achieve these goals through 4 key Second, strengthen sectors and countries. The third one is investing in risk reduction, which is more cost-effective than responding after disaster occurs. And management is a proactive and a structured process, focused not only on response, but also on prevention, planning, and resilience. This brings us to the emergency management cycle. It has 4 phases: mitigation, preparedness, response, and recovery. The circular diagram emphasizes that this is a continuous cycle, not a linear process. Let's start with the first phase, mitigation. Mitigation refers to all the long-term measures aimed at reducing the impact of disasters before they happen. It is essentially about trying to prevent hazards from becoming disasters, or at least minimizing their consequences. These actions can include building safer infrastructure, such as hospitals, urban planning, avoiding construction in high-risk areas, public health measures like vaccination programs, for example, and environmental protection, for example, preventing deforestation to reduce flood risk. The key idea here is that mitigation is often invisible in the short term, but extremely effective over time. In fact, investing in mitigation usually costs much less than dealing with the consequences later. Building on mitigation, the next step is preparedness. Preparedness is about being ready to act when a disaster occurs. While mitigation reduces risk, preparedness ensures that when something happens, we can respond quickly and effectively. These include developing emergency plans and protocols, training healthcare professionals through simulations and drills, ensuring availability of equipment and supplies, including pediatric-specific materials, and establishing clear communication systems. Preparedness is especially important in healthcare because even a well-resourced system can quickly become overwhelmed if it's not properly organized. Once a disaster occurs, we move into the response phase. This is the immediate action phase, focused on saving lives, reducing further harms, and meeting basic needs, such as shelter, food, and medical care. Key elements here include coordination between teams and agencies, the use of structured systems like the incident command system, triage to prioritize care when resources are limited, and evacuation and patient distribution to avoid overloading facilities. So an effective response depends heavily on how well we have prepared beforehand. Finally, after the initial response, we enter the recovery phase. Recovery focuses on restoring and improving the health and functioning of individuals and communities. This includes physical rehabilitation, mental health support, which is especially important in children, rebuilding health systems and infrastructure, and restoring essential services like education. Recovery is the longest phase, lasting months or even years. And it's not just about returning to the previous situation, but about building back better, creating systems that are more resilient for future disasters. For children, recovery is critical because disruptions in health, education, or family structure can have long term consequences on development. Now, let's focus on children. 1 billion children are at high risk from climate related disasters. Children are more vulnerable because they are physiologically different, they depend on caregivers, and psychologically they are more fragile. This image highlights why children are more vulnerable in emergencies. The key message is that children are not just small adults and their needs are different. For example, children breathe more air relative to their body size, so they are more exposed to substances. They also spend more time closer to the ground and ants. From a medical perspective, children require specific medications, vaccines, and equipment, which may not always be available during emergencies. In addition, they may have difficulty in communicating their symptoms or needs, especially younger children. So, overall, children have greater physical, developmental, and social vulnerability, which must be specifically considered in disaster planning and response. Now, let's discuss pediatric surge capacity. This refers to the ability to manage a sudden increase in pediatric patients. That is due to the fact that the proportion of pediatric victims usually mirrors the affected population demographics. This image illustrates the concept. On the left side, during a normal situation, children are allocated to adults. Pediatric beds are limited and sometimes even used for adult patients due to demand. In contrast, on the right side, during a disaster, the situation changes dramatically. The proportion of pediatric patients can rise to around 60% or even more, especially when the entire population is affected. To manage this, hospitals need to activate surge capacity, which means rapidly increasing pediatric resources, for example, converting general beds into pediatric ones. The key message here is that disaster response requires flexibility and rapid adaptation, ensuring that healthcare systems can provide appropriate care for a sudden increase in pediatric patients. These slides highlight some of the main operational challenges in pediatric surge capacity. First, we need to consider equipment. As you know, children require specific airway tools, ventilators, and monitoring devices adapted to their size and physiology. In a disaster, these resources may be limited, especially in hospitals where usually adults are treated. Second, there's the issue of medication and dosing. Unlike adults, children require weight-based dosing, which increases the risk errors in high-stress situations or when staff are not used to treating pediatric patients. Another key challenge is the need for family-centered care. Children are often accompanied by caregivers, and during disasters there may be a separation or displacement. So hospitals must plan for family reunification and ensure that children are not treated in isolation. Finally, we must not forget the psychological impact. Children are particularly vulnerable to stress and trauma, so providing psychological support is an essential part of care, not an optional one. Finally, why do pediatricians play such a key role? Pediatricians must participate in planning, collaborate across sectors, educate families, and continue training. For the American Academy of Pediatrics, the key roles of pediatricians in disasters are: first, pediatricians should be involved in all phases, including planning, response, and recovery, to ensure that children's needs are properly addressed. Second, we need to work with other sectors, such as emergency services, public health, and community organizations. We also have an important role in education, helping children and families prepare for emergencies and promoting resilience. And finally, pediatricians should pursue continuous training in disaster medicine, so we are prepared to respond effectively when this situation occurs. Um, Now it's the turn of Roy.
Yeah,
Hi.
thank you very much. It's our pleasure to introduce Dr. Roy Campos, who is a consultant pediatric in pediatric intensive and neonatal transport units. He has zealous of experience. I'm sure he will be an excellent asset for us tonight. So the floor for you, Dr. Roy.
Thank you very much for the presentation, and thank you for the opportunity of being part of this webinar. Can you hear me well? Just double checking before I start. Hello?
Yes,
Doctor.
Yes? Okay. Christina, can you start with the first slide, please? So we're going to repeat this concept because we think it's very important that the mass casualty incident is not strictly defined by the absolute number of victims, but rather by the imbalance between the demand for care and the available resources. So it's when the number of severity of patients exceeds the capacity of the system to respond using standard procedures that disaster protocols must be activated. So the disaster triage in mass casualty incidents represents a fundamental shift from the routine clinical practice. In everyday medicine, our goal is to provide the best possible care to each individual patient. However, in a mass casualty incident, this paradigm changes completely. The objective becomes maximizing overall survival within the constraints of the limited resources. Can we Thank you. In this context is when triage becomes the cornerstone of the medical response. Triage is the process of sorting patients according to the severity of their condition and their likelihood of survival. For even though this must sound tough. The aim is to prioritize treatment and allocate resources efficiently. The underlying ethical principle is to achieve the greatest good for the greatest number of people. This means that clinical decision making shifts from what we said about an individual centered approach to a population based strategy. It is important to recognize that triage is not a diagnostic process. We're not going to diagnose patients, but it's a rather rapid prioritization tool designed for use in these highly dynamic and resource limited environments. A key characteristic of disaster triage is speed. Decisions must be made in seconds, often under chaotic and stressful conditions. For this reason, triage systems are intentionally simple and rely on easily accessible clinical parameters. The next one. The balance between speed and accuracy is critical. In the initial phases of an incident, rapid classification is more important than precise diagnosis, and a certain degree of inaccuracy is acceptable. Moreover, triage is not a one time decision, it is a dynamic process that requires continuous reassessment as patients' conditions may change rapidly over time. Several triage systems have been developed to standardize this process. One of the most widely used one, and the one that we want to present to you because we're using it um, in our healthcare system, is the simple triage and rapid treatment, or as you can say from the acronym START algorithm, which is primarily applied in adult populations. START was developed in the 80s as a rapid, simple, and reproducible triage tool based on basic clinical parameters such as respiration, perfusion, and mental status. These elements allow clinicians to categorize patients into priority groups within less than 30 seconds. It categorizes patients into four color coded groups. Red means immediate attention needed, yellow, delayed attention needed, green, minor attention needed, and black means disease or expected attention needed, meaning that we should not focus on these patients. The simplicity allows it to be used with a wide range of providers, including physicians, nurses, paramedics, and even non-medical personnel. This is very interesting because, as we said before, triage is not a diagnostic process, and that makes it easier for non-medical personnel. It has been described that physicians might struggle doing the process because we are more used to the individual care and we are more used to diagnosing and directly treating. That's why doing this procedure might even be easier for paramedics and non-medical personnel than for physicians. So, as we're going to describe it a bit, and you can see in this chart that patients who can walk are initially classified as a low priority. So, this is like a very clear difference. Among those who cannot walk, the presence or absence of breathing, signs of adequate perfusion, and the ability to follow commands determine whether they are classified as immediate, delayed, or black disease or spectrum. The simplicity and speed of the START protocol have made it a cornerstone of the pre-hospital disaster response worldwide. Next one, please. So, how useful is it? Well, this meta-analysis included 32 studies evaluating the accuracy of the STAR triage system, mostly based on simulated mass casualty scenarios. To pursue real scenarios studies might not be ethical. That's why most of the trials are based on simulated scenarios. So overall, START show moderate performance. What does that mean? So they saw that the accuracy dropped significantly in the yellow or intermediate group to about to 60%, suggesting a difficulty in correctly classifying patients with moderate severity. Regarding the errors, over triage occurred in approximately 14% of the cases, while under triage was around 10%. Although under-triage rates were relatively low, they remain clinically significant due to the risk of missing critically ill patients. Over-triage, while less dangerous for patients as individuals, can strain limited resources during disasters. Star performance is not consistent and may depend heavily on the context and especially on the training. Next one, please. However, applying adult-based triage system to children is problematic. Pediatric patients present, as we all know, unique anatomical, physiological, and developmental characteristics that significantly impact triage accuracy. Children have higher baseline heart rates and respiratory rates, more compliant chest walls, and a greater susceptibility to hypoxia and dehydration. Their airways are smaller and more vulnerable to obstruction. Additionally, children may not be able to communicate effectively or follow commands, making the neurological assessment more challenging. Emotional factors also play a big role, as healthcare providers may have a natural tendency to prioritize children, leading to potential over triage. Next one. So to address these differences, there is a variation of the start, which the name is Jump Start, that we recommend, and is the algorithm developed as the pediatric adaptation of START. Jump Start modifies the assessment criteria to better reflect pediatric physiology. For example, in cases of apnea, it includes the provision of rescue breath before classifying the patient, recognizing that respiratory arrest in children may be reversible. It also adjusts thresholds for respiratory rates and incorporates developmental considerations into the assessment of mental status. Next one. This systematic review on the Jumpstart protocol in pediatric disaster evaluates its performance compared to other triage systems. Although Jump system. Some studies show it performs worse than alternatives like SALT or CareFlight in identifying critical patients. But the conclusion is that no triage system demonstrated consistently high accuracy, highlighting that overall limitations in current methods. That means that even though it might perform worse in others, since we have already used a start and this one shows accuracy, we are still using this. And we're going to see this on the following slide. So this article on the accuracy, efficiency, and inappropriate actions in Jumpstart examines how medical students apply this algorithm in mass casualty simulations. As we say, that is the only scenarios that we can assess. It reports an overall accuracy of 86%, which is quite high, and an average triage time of about 70 seconds per patient. Remember that the start one was closer to 30, 40 seconds, but this modification makes it a bit slower. However, more than half of participants performed unnecessary actions or omitted key steps, which increased triage time and reduced efficiency. The study emphasizes that correct execution of the algorithm and target training are critical to improving triage performance. We're going to see in the following one a randomized trial comparing the jump start and the SALT in a simulated pediatric mass casualty, where there were no significant differences in over triage or under triage rates, which is what we are more concerned about. Both were considered very easy to use. However, in this one, jump start was faster, averaging 26 seconds per patient compared to 34 seconds with SALT. As you can see, numbers really vary in the different studies. This study identified cognitive, emotional, and technical errors, with emotional bias particularly affecting pediatric triage decisions, as we had already commented. Overall, they say that Jumpstart offers a speed advantage despite comparable accuracy. The last one, the simulation basis. No, no, previous one. Sorry. The one on the bottom right, the simulation based study comparing three different ones, which are Jumpstart, Smart, and one clinical decision making, found that the Jumpstart achieved higher overall accuracy than the other approaches. It significantly outperformed SMART and clinical judgment, particularly in correctly identifying red, which are critical, and yellow, which are delayed patients. No major difference were observed between SMART and the clinical judgment alone. The study also showed that prior disaster training improved triage accuracy, while experience level did not. Overall, again, Jumpstart appears to be a more reliable algorithm for pediatric disaster triage in simulated scenarios. Both START and Jumpstart are basic initial triage systems. Now we can go to the next one. Thank you, Christina. Beyond basic triage systems, more advanced models have been developed just to improve the decision making in complex scenarios. They are going to be used in two different phases. We're going to use the two more simple ones on the terrain where the mass casualty have happened. And we're going to use the advanced one once we have the patients in the hospitals. One such model is the Spanish pre-hospital advanced triage method, known as META. This system builds upon the principles of advanced trauma life support because we consider that all these patients are going to be trauma patients and incorporates additional factors such as anatomical injuries and mechanism of trauma. Next one. Thank you. So, as you can see, Meta is structured as a multi-step process that includes stabilization triage, identification of patients requiring urgent surgical intervention, who would benefit from a rapid transfer to a surgical facility. This introduces the concept of surgical priority, allowing these patients to bypass certain stages of care and receive definitive treatment more quickly. This approach not only improves individual patient outcomes, but it also optimizes overall system efficiency by ensuring that critical resources are used where they can have the greatest impact. Evidence from comparative studies suggests that Meta may offer improved sensitivity and specificity compared to more traditional triage systems, as we saw. It highlights the potential benefits of incorporating advanced clinical judgments into triage decisions, even though it really has a function in a different stage. Despite these advantages, it is essential to acknowledge that no triage system is perfect. Both over triage and under triage are inherent risks. Over triage occurs when patients are assigned a higher priority than necessary, potentially overwhelming limited resources. And under triage, on the other hand, involves failing to identify critically ill patients in a timely manner, which can have severe consequences. In practice, a certain level of over triage is generally considered acceptable in order to minimize the risk of under triage. Achieving the right balance between these two is one of the central challenges of disaster medicine. Next one. So, the ethical considerations are deeply embedded in the triage process. In disaster scenarios, clinicians are often required to make difficult decisions about resource allocation under conditions of uncertainty and pressure. Principles such as justice, utility, and equity provide a framework for these decisions, but they do not eliminate the emotional burden associated with them. A key issue is the shift, as we said at the beginning, from this individual centered care to a utilitarian model, where decisions prioritize saving the greatest number of lives rather than treating all patients equally. This creates a moral dilemma, particularly when severely injured patients may receive no care. Another major ethical concern is over triage and under triage. Um, Over triage again allocates scarce resources to less critical patients, potentially harming those in the urgent need, while under triage fails to identify critical patients, increasing the risk of preventable mortality. Evidence shows that systems like START can produce mismatches between assigned categories and actual patient needs, highlighting fairness and accuracy concerns. Healthcare professionals also face moral distress and psychological burdens when forced to make rapid life and death decisions under pressure. The classification of patients as expectant and likely to survive is particularly controversial as it conflicts with core medical values. Finally, differences in training, system design, and patient characteristics can lead to inconsistent decisions, reinforcing concerns about equity, justice, and the ethical responsibility to optimize both accuracy and fairness in triage. Next one. It is important to emphasize this is the plan that we have um, for this sorry, for these mass casualty events in our hospital. We are not going to go through it, but it is important to emphasize that the effectiveness of the triage depends not only on the algorithm used, but also on the broader system in which it is implemented. This plan that I'm showing you highlights the importance of coordination between the pre-hospital and the hospital care, structure activation levels, and clearly defined roles and responsibilities. We can go, you can push a bit. Yeah, here you go. As you can see, the initial triage is performed at the scene using systems such as START, followed by advanced triage methods like META, and subsequent reassessment upon the arrival at the hospital. Multiple triage points, efficient communication, and organized patient flow are essential to ensure that the system functions effectively. So, in conclusion, disaster triage is a complex and dynamic process that integrates rapid clinical assessment, ethical decision making, and system level organization. While triage algorithms provide essential guidance, they are only one component of an effective response. The ultimate success of the disaster management depends on preparation, training, coordination, and the ability to adapt to a rapidly evolving situation. In this context, the system is often more important than the algorithm itself. Thank you.
Okay, then now that we have covered general concepts and triage, let's move to the final part, disaster preparedness plans. We will focus now on why disaster plans are essential, their objectives, and how they are structured at different levels. Sorry. Disasters can overwhelm healthcare systems very quickly. Without proper planning, coordination fails and mortality increases. Preparedness improves survival and system resilience. So, disaster plans aim to ensure continuity of care, optimize resources, establish coordination, protect patients and staff, and maintain communication. These are the pillars of an effective response. Disaster planning occurs at three levels: community, pre-hospital, and hospital level. The image shows how all levels must be connected and coordinated. Let's start with the community level disaster planning, which is the foundation of an effective response. At this level, the focus is on prevention, preparedness, and coordination before patients even reach the healthcare system. The key elements here include risk assessment, education and training, and coordination between sectors. As a risk assessment, it is to identify local hazards such as extreme heat, floods, or mass gatherings. Public education ensures that families know how to respond in an emergency, and coordination between sectors include healthcare, schools, emergency services, and local authorities. For pediatric care, community planning is particularly important because children depend heavily on family and social structures. So the key idea is that a strong community response can reduce the number and severity of cases arriving at hospitals. Building on that, we move to the pre-hospital level, which acts as the bridge between the disaster scene and the hospital. This phase is critical because early decisions influence outcomes significantly. Pre-hospital planning includes emergency dispatch systems, triage and transport, and real-time information. The emergency dispatch systems ensure rapid activation of resources. The on-site triage, as we have seen, prioritizes patients based on severity. The safe transport allows to direct patients to the most appropriate facilities. And the real-time communications allows hospitals to anticipate incoming patients. For example, during a mass casualty incident, correctly identifying and transporting critically ill children to pediatric capable centers can significantly improve their survival. So effective pre-hospital coordination helps prevent chaos and hospital overload. Now, once patients arrive, we enter to the hospital level, which requires highly structured planning. Hospitals must be prepared to rapidly shift from routine care to crisis mode. This involves activating a hospital emergency operations plan, which defines roles and responsibilities, communication channels, and operational priorities. A key concept here is the incident command system, which ensures that decisions are made clearly and efficiently, even in chaotic situations. Expanding on this, hospitals must also manage resources and capacity. During a disaster, demand can increase suddenly, so hospitals need to expand bed capacity, including converting adult beds into pediatric ones if necessary, ensure availability of equipment and medication, including pediatric-specific supplies, and maintain adequate staffing. This is where the concept of surge capacity that we've just discussed becomes critical, not only increasing the number of patients we can treat, but also maintaining the quality and safety of care. Another key concept of hospital planning is communication and coordination. In a disaster scenario, failures in communication can lead to delays in care, duplication of efforts, or critical resource shortages. Effective systems must ensure internal communication between departments and teams, external communication with emergency services and public health authorities, and clear information for families, which is especially important in pediatric care. Finally, disaster planning must include safety and infrastructure preparedness. Hospitals themselves must remain functional during disasters, which means ensuring structural safety, especially in earthquakes or floods, maintaining power, water, and oxygen supplies, and protecting critical areas, such as emergency departments and intensive care units. This image summarizes the key components of hospital disaster preparedness. You can see that hospitals must be ready to rapidly shift from normal operation to crisis mode. This involves activating an emergency operations plan with a clear command structure, ensuring effective communication between the hospital and with external services, managing resources such as expanding beds or adapting care for pediatric patients, and maintaining patient-centered care, including clear organization, coordination, and flexibility to provide safe and effective care under pressure. So, to conclude this section, let's highlight the key messages. First, disasters are increasing in frequency and complexity worldwide, driven by factors such as climate change, urbanization, and global instability. This means that we are likely to face this situation more often in our clinical practice. Second, children are disproportionately affected by disasters. Their psychological, developmental, and social characteristics make them more vulnerable, and their needs are often overlooked if they are not specifically included in planning. The third one is that preparedness is essential. Effective disaster response does not start when the event happens. It starts long before, with planning, training, and coordination at all levels. Community, pre-hospital, not only caregivers during the response phase, but also key contributors to preparedness, planning, education, and recovery. So, the main takeaway is that improving outcomes for children in disasters depends on anticipation, coordination, and ensuring that pediatric needs are fully integrated into every phase of disaster management. To conclude, effective disaster response starts before the event and must include children at its core. Thank you very much for your attention. We will be happy to take your questions and discuss any points further.
Thank you so much, Dr. Christina and Dr. Roy. And as we come to the end of this webinar, I would like really to extend my sincere thanks to all of you and your participation and the valuable engagement today from San Juan. Really, it's very nice that we always find our friends, our colleagues, the distinguished speakers, that's you, Christina and Roy. And of course, Dr. Muslim, he's there also. And to the team of the Hospital of San Juan in Barcelona, to their continued commitment to advancing pediatric education with us. Any questions there or anybody raise their hand? So they are just saying, great lecture, thank you so much. they're thanking, but so far, thank you, Zahra. There's no question. So maybe you'll wait 2 minutes more. And again, someone said, thank you so much for this webinar. And yes, based on the percentage and any special education you recommend to the adult, to the adult doctors. And a lot of people thanking you, Christina and Roy. So you got the question now, Christina, Roy? Yeah.
Yes, this is an important question. I think that adult doctors should be prepared and should be educated in how to manage pediatric patients because they are different when they are victims of disasters or mass casualty situations. Emergencies in pediatrics, especially pediatric basic life support or pediatric trauma. One of the most pathology that you are going to maybe have to treat is trauma, is the trauma one.
Yeah, material, especially for adult or geriatric during disaster.
Any material?
Yeah, I don't know.
You mean tools, for example?
I think this is what they mean.
Yes. Yes, I would recommend resuscitation tools because pediatricians we always calculate dosing based with the weight of the patient and the age. So this is where you can see the dose for every patient depending on the height of the patient. In fact, pediatricians we use to make errors. I don't know if Roy wants to add something.
No, I completely agree with Christina that feasible and these applications might be very useful. Also, I think that it depends on like the trauma page for a website or something like that. So maybe PLS or advanced pediatric trauma support, like I don't know in English because every resource that we have is from our country, but um, maybe we could look this up and send it to you if we find something else. I agree with Christina, but if they are asking for more concrete resources like websites where to do some training, we definitely would need to look that up in English for you because the only resources that we have are basically apart from the resuscitation like the European Resuscitation Council website, where you can get a lot of information. Maybe that's the more accessible tool that you can get to train.
Thank you, Roy. A disaster management leader in the Middle East conflict area. What is your priority? Sorry, the question. What is your first priority and why? Thank you. That was his question.
I think the first priority would be to establish a rapid and effective triage and basic life saving care capacity. This is the most important because you will be in a chaotic the first patients to be seen and you will be able to decide which resource is better for one or another. It's very important all the actions you make before the disaster occurs. If you have a good planification, you will have a more effective response. It's like that. If you wait to be during the disaster to decide what to do, then the response wouldn't be so good. In our hospital, we made our disaster preparedness plan when we lived all the terrorist attacks in Europe, and so we were asked to organize our answer to know when you can give a better response.
Thank you. I think Dr. Muslim will start to be with us. Oh, okay. So there's Debbie is asking a question. Sorry, it went up because a lot of question there. Yeah. How does moral distress affect decision making among nurses and healthcare professionals? So we do have a lot of questions there.
I think this is more related with triage, these moral issues and the distress. As we said, when you are changing your practice from more individual center to maximizing resources, you need to understand and to work without thinking about this sounds tough, but you need to not think about the people that you're facing. You just need to think about the resources and make the triage as fair as possible. And that's why you really need to rely on fair protocols to use it. So most of the people after doing it are going to need psychological support because you're doing something for the specifically needs. I don't know if this answers the question.
Yeah, thank you, Dr. Rai. So children during the disaster, and what role does the family-centered care play in pediatric disaster nursing?
This is a very important question because we have to try to maintain the unity of families. For example, if it's better to treat a child in an adult hospital or an adult in a children's hospital than separate children and its family. This is a strong recommendation made by several associations because children are at risk when they are separated from their families. Their families can relieve their trauma, their stress. So if it's very important to maintain this unity. If it's not possible, then nurses should ensure that children are with adults that can care about them, and they should try to communicate with these children. And sometimes it can be difficult if they are young children or if they are very scared. So it's a great challenge here to the role of nurses with family-centered care.
Yeah, and another question, what is the function of HEICS? This is Hospital Emergency Incident Command System in the internal management structure of a hospital during disaster. Do you have that?
Sorry, I haven't understand
So
the
the question
question.
is, what is the function of
See, function, okay.
HEICS, Hospital Emergency
Yes.
Incident Command System in the internal management?
Yes. This is a very important question because this system is the system when you change your normal situation and you shift to a disaster situation. It implies that the command system in the hospital has to change. You have to create a crisis committee that is going to take all the decisions about changing the normal functioning of the hospital, about the staff. It's a big change change that the hospital has to lead, and the hospital emergency incident command systems defines all the chain of command and avoids confusion because you function in a different way. So the H has to give a response to operations, planning, logistics, finance, and after the first moments to communication, etc. So it's all the system. You create a new system, a different one from the normal situation, where you have the crisis committee who is taking all the decisions, and you restructure your normal functioning.
Thank you so much, Christina. So now we come to the end, and we are concluding everything. Thank you so much, and thanks, Dr. Roy, Dr. Muslim, and Mustafa there. He is our organizer. And thanks, Patricia, Vera, for arranging all of this in the last few weeks and making the 3 series webinars from San Juan. So I'd like to remind everyone we do have on the 18th of May another webinar with San Juan. And it will be different material there. So keep it in your calendar, please. And thank you once again for joining us, our audience. And we would like to forward to seeing you soon in our next webinars. Thank you so much and have a good night. Thanks,
Thank you.
Christina.
Thank you very much. Bye-bye.
Thank you. Thank you
Thanks,
very
bye.
much.
Recording stopped.